had one particular patient in mind, a young woman with the triple negative, 40s, has kids. And she's, she just said, I want to get my kids through high school. And that timeline is come and gone, right? Her son has graduated from high school and she's still around. She's still with us. So those are the stories that really, like, I have goosebumps right now.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Bridget Oppong. Bridget is a surgical oncologist who specializes in breast cancer surgery, and she is also the Deputy Director of the James Center for Cancer Health Equity. Bridget will fill us in on the importance of detecting breast cancer in the earliest stages and how this saved lives, what women need to know about screenings, new advances in treatments and surgical techniques, and also how the James and the Stephanie Spielman Comprehensive Breast Center are making a big effort to reach out to underserved populations in Columbus and throughout all of Ohio, and why this is so important. Welcome to the podcast, Bridget.
Thank you so much. Thank you for that kind introduction, and thank you for having me.
We have a lot of ground to cover, but I thought I would start. I read something in your bio that I thought was really appropriate, and I want to read it to you and have you kind of explain it. You wrote that your aim is to be an educator and advocate, which is perfect because that's what we're doing right now.
Right.
But explain what that means to you and why that's important for you.
Sure. So first off, I definitely do see myself as an educator, really first and foremost. A lot of what I have to do is explain to patients what the condition that they're coming in with, which is majority breast cancer, what that means to them, because people come in and they hear cancer is a big C word, and there's a lot of imagery, there's a lot of feelings, there's a lot of thoughts that they have about what that means to them, what that's going to mean for their families and for their futures. And a lot of what I'm able to do is to review the information that we have and really put all of that in context. The other thing I have to educate patients on is treatment. Okay, you have this condition, here's what you can do about it, and educate you as to why you should do it. Because a lot of times, especially in breast, things are a choice. Patients,
right.
Obviously, patients have autonomy. We want to make sure that they're making the right choice. And in order to do that, I have to properly educate them on the pros and cons of one option versus another. So I take that education component very seriously. And also when it comes to addressing health disparities, I think that's a huge tool in my armamentarium, is to be able to educate the community, educate people who may not be screened, but may not have the awareness, may not have the knowledge of why screening, for example, is important, or why, if something is noticeably different in the breast, that it should be brought to medical attention.
Yeah, I think for the general public, there is a lack of knowledge, and that having someone explain it to them, it just reduces fears and anxieties, and it makes them feel as if they can take charge of their own care.
100%. I think I was also, talk about educator, I actually was interested in being a school teacher, back in the day, and I taught very briefly because it's such a hard job. But just with that experience, I really, again, take it very seriously, because you're right, we forget things like anatomy, right? I mean, you learn all of that back in, 8th grade, right? So you imagine we're seeing adults, and the average age that for women in this country to be diagnosed is about 60. So people don't know sort of they don't know the anatomy. They don't know what lymph nodes are. So some things that I think for us in medicine or anywhere in healthcare, we kind of take for granted, that a lot of people in the community just don't remember that stuff, just don't have an idea of the significance of it. So we really have to drill down. And I've learned to just be very minimalist, and I obviously you scale up based on the individual's education level or their overall knowledge. Thanks to Google, a lot of people come in armed with some researching, some Googling that they've done to help. But we have to explain, this is the breast, this is the cells that make up the breast, this is what the breast does, this is how problems start, and this is when there's a tumor, or if there's any abnormal changes, this is what it can do to the skin. So we really take time to explain all of that at the visit. And just like you said, a lot of that education, by the end of our consultation, for example, people are relieved, because I think that information really does empower them, and it really does allay their fears, because we explain to them, this is not a death sentence in most cases.
Good. Well, let's get into that, and it might be appropriate to say, since you're a former teacher and still a teacher,
Right.
class is now in session.
That's right. Let's hit it.
So, why is it important to detect breast cancer in those early stages?
So breast cancers, like most solid tumors, what they do is that they grow, right? So they grow, and what we call staging, which is based on the tumor size, also lymph node involvement, and whether there's any disease inside the body, that is the classification in breast, for example, that's 0 to 4. So we have information that an early stage diagnosis, a woman who has that or a man who has that, will do better than somebody who unfortunately has an incurable stage 4 disease.
A stage 4 that is spread to other parts
Exactly.
of the body.
Stage 4 means it's spread internally, whether it's to the lungs, the liver, some internal organ. That's the only space where really this is not incurable. Now, with that being said, we still have management for it. We can contain it, and patients can actually live a really long life in many cases, even with the stage 4. But the focus when we talk about screening is on early detection, because it is life-saving. When we find something that's early enough that we can do surgery, we can do some of the other therapies that we have for breast cancer, we know that the survivability is excellent. The survivability for early stage cancers, for example, the 5-year survival is over 90%. So that's really important for patients to realize that. That's the first thing I say when I see them. I look at my patients and I said, "You're going to do fine. You're going to do fine. This is a little tiny cancer. You didn't feel anything. This was screen detected, and this is why it's a good day for you, despite having this diagnosis." And automatically, I can see just the fear dissipate once you say that, because you put things in perspective. But it's because of that data that we know that screening is really essential.
Okay, so let's talk about there's numerous screening methods. I think now, of course, we'll get to the yearly mammograms and why that's important. But even before that, self-examinations are key. So explain how to do it and how often women, and you did mention men can also get breast cancer,
Absolutely.
much lower rate, but they can. So
Yes.
what are self-examinations? How do you do it?
So the first thing is a visual inspection. I tell patients, just look in the mirror. And actually, just to put things in context, self-examination, I think, has been controversial when it comes to as a screening methodology, right?
You meaning if that's your only method?
Exactly, if that's
Yeah,
your only
right.
method. And I think because of some anxiety produced with some women who have a lot of, let's say, fibrocystic changes, which are benign, there's a lot of anxiety. So I think some...
Meaning they could feel something.
They can feel something all the time,
yeah,
exactly. So the
but
patient's
no.
like, well, I don't want to feel my breast because I'm always feeling something and it just stresses me out. So those are patients where like, okay, you know what, just don't do it. But obviously you have to get your screening.
yeah.
But outside of that situation, I always advocate for self-examination because you need to be familiar with your baseline. And with that, again, is a visual inspection. Stand and look in the mirror. So that's the first thing you do. Compare the sides, make sure that there's no asymmetry. Make sure there's no skin changes, make sure there's no dimpling. That's number one. Next is the palpation or the touching. And that you want to do in different positions. You can do it straight on, or if you're seated, and then you can do it or with the arm up. So I think it's important that women know to change position, because if there is an abnormality, the change in position makes it easier to see and to sometimes feel. All right, so I think that's really important. And as far as the frequency, I tell patients do it once a month. And I always say pick your birthday. Like my birthday is September 12th. Just passed. So the 12th is my day. And if that's a day I'm going to do the self-exam and just check and make sure everything is good. And the key is compare to the other side. Compare to the other side and say, hey, this side feels a little bit different, and confirm. If it's symmetric, that's most likely benign. But the caveat is anything that's different, bring it to medical attention. Call your PCP, call your GYN, call your surgeon, have somebody look at it.
Okay, that's a great advice. If you feel something different, call your primary care physician,
Exactly.
oncologist, and you want to come in for screening.
Exactly.
Okay,
Exactly.
so screening, which is, I guess, the most common is mammogram. So how often and what happens during a mammogram?
So the screening, first off, there's different recommendations, but at the James, we go by the NCCN guidelines. So I tell my patients to start at 40. Start at age 40, and it's annual. Now, part of the sort of the difference or the controversies, if you will, is really based on tailoring or individualizing screening, which we should, and really we're in the era of precision medicine as much as possible. So everything that we're doing as physicians now, we're trained to, it should be holistic, right? So I'm going to see a patient and say, yes, I recommend in general women start getting screened at 40. But if you have a significant family history,
Right.
if you have women in your family that have had cancers, breast, ovarian cancers, for example, at younger ages, I'm going to start you screening earlier. I want to start screening 5 to 10 years before the onset of the youngest affected. Hopefully that makes sense to people listening. So it's really important. If you have a cousin who was diagnosed, or a sister or mother, let's say that's even closer in the degrees, who was diagnosed at age 35, I want to get you started screening at age 30.
Okay.
At the latest.
So self-exams, you should start even earlier, right?
Absolutely.
And
Self-exams, I tell everybody to do self-exams. Everybody should do self-exams. It's not something I want to sort of burden young women with, but even, I have daughters. I want them to look. I want them to have that comfort with their bodies, because the youngest patient I've diagnosed was a teenager.
Yeah.
And of course that's not screening age, right? But we also see some lesions, usually they're benign, thank goodness, but we do see some breast pathology, fibroadenomas, juvenile phylloides tumors, for example, in younger women. And those are all by exam. And oftentimes it's something there, and these young women just don't trigger any sort of concern or don't know to bring it to anybody's attention until it's massive, until there's an obvious deformity in the breast. So I really start encouraging that women start being comfortable, being familiar with the breast, being comfortable with the texture of the breast as early, as they're comfortable doing. But definitely when women are older, after 25 or so, monthly self-exams, it's great. Because the other thing too is, if we look at the epidemiology, we're seeing breast cancers being diagnosed in younger women.
I've heard that, yeah. And do you know why?
So we don't have a reason, whether it's environmental factors, whether it's, obesity is possibly a trigger for it, because most breast cancers are hormonally driven. But we are seeing it in younger women, and particularly in the minority communities, even younger. It's already younger, but now we're seeing it excessively. So these are women who are pre-screening age. So those are women who the only way we find this cancer is if they themselves identify an abnormality and seek medical attention.
Wow. So let's talk a little bit more about family history and genetic mutations. So when you're talking to someone, what do you ask them about their family history, and what in their family history, you mentioned a little, but what would indicate someone that should be screened earlier?
Sure. So first thing is any history of breast cancer, obviously. And then we want to talk about any history of ovarian cancers or some, because I would say the initial genes that were identified were the BRCA1s and 2s, and especially
the breast cancer genes.
Yes, breast cancer genes, yes. And those BRCA1 specifically, and 2 actually, focus on breast and ovarian. But there can be other, like pancreatic cancers. There can be other types of cancers within the family line. So that in itself, if there's just a huge cancer history, people say, oh yeah, everybody in my family has had cancer at some point. That's a concern to me. And we literally will draw a family tree. So let me know who has what and the age. So that's the other thing that's really important. Because if grandma or your mom has cancer at 70, then that's not a genetically driven kind of disease, right?
That's an environmentally...
Exactly. Or is a byproduct of aging, unfortunately, because that's what cancer is.
So if someone's... So the BRCA is passed on. Mm-hmm. So if someone is identified that your mother, or it can be passed on by either parent.
Yes, it's a dominant gene, yes.
So if you know that someone who, if you're a parent and you have that, what does that mean for your children? Do they start screenings earlier?
Yes. So if we've identified a BRCA mutation, for example, then the children, it's dominant. So it's 50-50 if the children will be affected. So when age appropriate, usually my sort of initiation period is after 25 or so. I recommend that we test that individual. as well. So all the family members should undergo testing, and men and women,
To see if they have.
to see if they're
yeah.
also carriers of the gene, exactly, because that is going to impact a known mutation carrier. We screen still, but it's more intense. So that's the group where we may recommend supplemental imaging, for example, MRIs in conjunction with the mammograms.
Okay. I've heard, and we have from Dr. Ramaswamy, who recently passed away,
Yes,
was a real
unfortunately.
pioneer and expert on the connection between breastfeeding and breast cancer. So what did her research sort of show that you talk to patients about?
So that breastfeeding, and this has sort of been established, and definitely, as you said, Dr. Ramaswamy was a pioneer in many facets, many aspects of how we treat breast cancers and how we screen today. So through her contribution and others, we know that breastfeeding is actually protective. So breastfeeding should be highly encouraged because of the benefit for the baby, but also it does have a benefit for the mother.
It reduces the risk
It
of breast cancer.
reduces risk of
Wow.
developing breast cancer. So it definitely is protective. So again, we encourage it. And that's because those hormonally driven changes, we don't have the mechanism yet. That hasn't been worked out as to the why, as to the causality, but we do have studies that show that there is a risk reduction with breastfeeding.
So does that mean that women who don't have children for whatever reasons might be at a higher risk than women who do have children and breastfeed?
Yeah, so there is that data as well. So women who have children younger, there's a protective effect. And sometimes you have to be careful when you say that. I don't want, parents calling me my teen. I don't want teens having kids. But we know that
Right.
the younger age women, there is some protection there with breast cancer. There's also protection against, with the extreme being women who never have children, who are, who have never born any children. That's sort of the comparison group. So childbearing is protective. And then if you do get pregnant, we recommend breastfeeding to add to that.
Okay, so it seems to me that there's almost like a fine line. We don't want to scare people, but at the same time, you want to educate them so they take the appropriate steps to protect themselves and catch things early. So
Yes.
I feel like that's sort of that fine line you're always walking.
Yeah. Oh, absolutely. Because, fear mongering, I think is counterproductive.
Yeah.
Especially in the communities that we go to. We go into communities that are underserved, vulnerable communities in many ways. And that sort of a fear-based approach, I think it's really just, it's a turnoff, right? That's not how you want people to come to it. I think it's about empowering people. It's about being factual. Like I want to be honest. You want to be transparent, right? Because a lot of these communities, we have to be aware, also have a certain amount of mistrust
Of organizations.
doctors. Yeah, definitely organizations. Definitely of the medical infrastructure as a whole. So we have to be careful when we go there and saying, well, you have to do this, and how you can't dictate certain behaviors. To me, the goal is education, so I can convince you, right, that, okay, you're armed with this information, and hopefully that information will propel you to make some lifestyle modifications or some modifications that you can do screenings for breast cancer and other cancers.
Okay, we covered a lot of territory,
We did.
and
We
we're going to take
totally
a quick
did.
break, and we have a lot more territory to cover,
That's
including
wonderful.
advances in treatment and
Yes.
your specialty surgery. So we'll be right back.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access.
To cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Bridget Oppong, and you gave us a great summary of screening and why it's so important. But let's talk about treatment now, which has really advanced in the past couple decades. So give us kind of the big picture on advances in treatment.
So just a quick overview. The treatment for breast cancers, and actually most cancers nowadays, but obviously we're focusing on breast, it's multimodal, what we call multimodal, meaning that there's different modes of therapy. There's surgery, which is what I do. There's medical therapy, and then there's radiation.
Medical therapy is chemo and immunotherapy.
Immunotherapy, chemotherapy, but also for breast cancer, since most of them are estrogen-driven, anti-estrogen or hormonal therapy. So we consider that's all part in the realm of medical therapy.
And that's why older women get breast cancer, because their hormones and estrogen change, right? Or,
so that's a mechanism. It actually doesn't make sense, because as women get older, you'd think the estrogen levels are dropping, right? So why is it that they're developing these cancers? So definitely the hormonal environment changing does impact breast cancer development, but the actual, again, the causality is really has not been worked out.
Okay.
It has not been worked out. So, but what we see, and this is based on the epidemiology, what we see is that the average age is about 60. So most patients are diagnosed after menopause, which will be counterintuitive because most of the cancers are estrogen positive.
Okay. So before we got sidetracked on that,
that's right.
you were going through the treatments.
I was going through. So think of it as 3 groups. There's surgery, medical therapy, which includes all of the chemotherapy, immunotherapy, as we said, and oral therapy through the hormonal agents. And then there's radiation therapy, right? So I tell patients, group it in terms of local therapy, what I'm doing to the breast or to the armpit, the axilla, because that's all local. And what, like the radiation doctors, for example, also are local, offer local therapy because they're treating the breast and they're treating lymph nodes, for example. And the people who treat inside the body, the systemic treatment, that's the medical doctors. All right, so it's those 3 groups. Now, within those 3 modalities, there has been ridiculous advancements, awesome advancements across all of that. And that is why the survivability of breast cancer, it's really changed. I mean, it's just 5-year survival now, it's over 90%. That is amazing statistics. And people are shocked to hear this because, again, we think of cancer and we just automatically, I think the next thought is death.
Yeah.
And we don't understand, or we don't immediately perceive that this is an incredibly treatable and curable condition in the vast majority of cases.
Now, when you say over 90%, is that for all stages?
That's early stage.
Early stage.
Thank you for stressing that. That's definitely early
Okay.
stage, yes.
And so that's why it's so important to detect
100%. That takes us back to why early detection is amazing. So I talked about just the different types of treatments, but as far as focusing on the advancements, within the world of local therapy, there's been a lot of advancement over the decades. When it comes to surgery, I think our surgeries have become less invasive. They've become more cosmetically conscious. I know that sounds like I should coin that term. I actually like that.
Cosmetically conscious.
Yes, because, we're oncologists, right? Our first goal, and it always will be our first goal, is cancer removal.
Yeah.
But how we do it now is very different because we also know, as I'm telling you, especially if these cancers are detected early, it's survivable. So now we know that we're treating a condition that will be a thing of the past in about a year or so. So I'm thinking ahead what this woman potentially may have to grapple with as far as self-image, as far as what the incision is going to look like, how it's going to impact your functionality. So it's because of that we're tailoring our surgeries in many ways. And I know we'll talk about my particular advancements, but that same concept is what we're doing when it comes to the radiation therapy, for example. We're shortening our duration. Now it's about 3 weeks. It used to be almost 2 months, right? By the time you had standard whole breast irradiation. And when I say that, patients are like, well, are they giving us less? And you're getting the same dose. Just now we're able to deliver it in a way that's smarter, in a way that protects the internal organs, and in a way that is not as prohibitive to your day-to-day because, our patients are parents, they're grandparents, they're working in many cases. So we want to be able to treat you so that you can go on and resume your life, your day-to-day activities. So it's really important for us to preserve that throughout your treatment and certainly afterwards. And the other advancements that we have, which is really the extremely fantastic and exciting and rapidly changing, is the medical advancements. And that's really all research driven. As we see here, we have the Pelotonia Institute and all of the immunotherapies that are because of that institute, because of the fundraising that people do, we've come up with immunotherapies that have really been game changers for certain subtypes of breast cancers, the triple negatives, for example, or the HER2 positives. Those were cancer types that were aggressive and really had a much worse prognosis. And sort of with recent treatment algorithms, that the outcomes have really been improved.
So
greatly.
for later stages of breast cancer, that's where the immunotherapy comes in, and that can extend life and improve quality of life.
Absolutely. And even in some cases, even when it's unfortunately metastatic, and again, these are cases where we can't cure, but we can maintain. So I tell patients, I don't even want you to lose hope if I'm telling you that unfortunately you're at a stage 4, because we do have these immunotherapies, for example, as you said. And we also have therapies that are targeted. Again, back to that word of precision medicine. We have technologies now that help us get genomic information from the cancer so that we can say, okay, this agent is going to work better for your cancer, instead of what we had to do before, which was just give a standard regimen and see how it works or how women respond. Now we have much of that information up front, especially in the more advanced cases, so we can be very intentional and precise about the agents that will work and will have a lower side effect profile.
It's kind of amazing in the last 10 to 15 years, the advances, and then they're still coming fast and furious.
Absolutely. Oh my goodness. I mean, the drug, the combination, the targeted therapies, it's been amazing. And I love that, because unfortunately we do have patients who have advanced disease. I can see that they're not responding. And when I get that call from the medical oncologist that, hey, there's a trial open, that this is a new agent that's been approved and it can work, and the patients actually get it, and they're still alive, they're able to see. I have one particular patient in mind, a young woman with a triple negative, 40s, has kids, and she's, she just said, I want to get my kids through high school. And that timeline is come and gone, right? Her son has graduated from high school, and she's still around. She's still with us. So those are the stories that really, like, I have goosebumps right now. Like, it's just is amazing to watch, because that's the fear. She's not afraid of dying herself. She's afraid of the impact of this on her children, on her family.
Wow. That is an amazing story, because it's happening all the time now.
All the time.
Yeah.
All the time.
Well, let's talk a little bit about some of the advanced surgeries that you perform. So, and I know that years ago, 40, 50, 60 years ago, it was really devastating, traumatic surgery that took away large portions of a woman's breast, if not the entire breast. Now you've become so precise.
Absolutely. We've been able to really aim for minimalism in a way of how we approach our cases. You want to take, obviously, the involved tumor out, but if you can get clear margins, that's a situation where we have enough data now that you can safely preserve that breast. You can do breast conservation, and those patients have to go on and have radiation, which again, those radiation protocols have also advanced so that it's shorter duration. It protects a lot of the internal organs, that the whole tolerability has really improved significantly. So the other thing for surgery that's really been amazing is the different techniques of, even for patients who need to have mastectomy. Now we're doing nipple sparing mastectomies. So those are patients who I'm saving all the skin, for example, and removing the tissue inside, about 90% of the breast tissue. That gives a superior cosmetic result, for example. And, sometimes I think patients feel like, well, it's not about vanity. I just want the tumor out. And I always stop them and say, you're going to get through this. Yeah. And I know right now you're thinking about, I just want the tumor gone. But I know in a year from now, that tumor will be gone, and you're going to be sitting there and perhaps, and some women are totally fine, but there are some who are really dismayed at their appearance, and how I'm thinking ahead for them, how that's going to impact their quality of life, because like we keep saying, this is a survivable condition, but quality of life moving forward is what's really important. So I'm altering my surgeries in a way that I can better preserve the cosmesis, better enhance the quality of life. But obviously, primarily, it has to be oncologically safe. We have that data now.
It's almost like a change in the mindset. In the past, it was, we have to do everything we can to save this woman's life, and now you've advanced so far that we can save her life and
exactly. We can save your life and still give you a result that you're comfortable with, that you're happy with. And also, it's changed. Like, now we have technologies where, if a woman is not satisfied, or some patients who have procedures, you know, at some of the rural spaces, for example, where they may not have, like the plastic surgeons, they may not have those sort of advanced surgical techniques. They come here, and even if it's delayed after, sometimes years later, we can still help them. So those are always wonderful things, because it's really difficult, especially for our younger patients, to sometimes not have any kind of reconstruction or not have a cosmetic result that they're happy with.
That's another reason why women, anyone who's diagnosed with cancer, but breast cancer, you should come to a comprehensive cancer center and a place like the Spielman that has dozens and dozens of experts like you in every area that is needed.
Absolutely. We're all there. And we didn't even talk about plastics. So I would say maybe more than half of my cases are done with plastics. And a lot of times patients are like, well, I don't need the plastics. Because again, you're
plastics
thinking of
meaning plastic
surgery.
Yeah,
yes.
not actual plastic.
Not plastic, yes. Thanks for the correction. But, you know, a lot of our cases are done with the breast surgeon in conjunction with the plastic surgeon, because again,
those are two different specialties.
Yes, yeah. and it's it's complex, because we have to schedule two teams, we have to sort of work together, but it really does give the patient a more superior result, right? Because the plastic surgeon has a different focus than I have. So of course I'm going to prioritize the oncology. They're also thinking about the the cosmetic appearance at the end of the cancer treatment, and I think it's important that we meet together early on so we can plan together, because sometimes if the breast surgeon goes on, you do what you need to do, you may burn bridges, right? You may do things in a way that may limit the plastic surgeon's ability to reconstruct the breast. So I think it's really, just like you're saying, it's really key that we have a system, we actually have a building where we're literally all there.
Wow. And another aspect of a comprehensive cancer center like the James is reaching out to underserved communities. And you do this with the Cancer Health Equity Center for all kinds of cancer. But let's focus on breast cancer and what you and the James and the Spielman are doing to reach women. And I know that Black and Hispanic women have some higher rates of breast cancer and some and worse outcomes. So
yes,
how do you address this, and what are some of your programs?
Yes, absolutely. So despite all the advancements, and I hope people have seen a theme through my time with you, that the advancements are real. They're across all the different treatment modalities. But despite that, we still see disparities. We still see,
how do we reach every woman with these advancements?
Exactly. How's everybody getting access to it? And that's what the Center for Health Equity, that's our focus, right, is to make sure that women and men have equitable access to all levels of cancer treatment across the continuum, and that's from the screening all the way through to survivorship. So that's what we're focusing on. For breast, we have a robust screening program that has outreach in all of the vulnerable communities. And by vulnerable, it's not just race or ethnicity, it's socioeconomic, right? So we have a huge contingent of our programs are in the rural spaces.
Where they don't have facilities. Exactly,
where they don't, especially now, post-COVID, a lot of the rural hospitals didn't make it, unfortunately, had to shut down or restrict their services, so there is definitely some spaces there where patients don't have coverage. So we do have a mobile mammography, a van that can go out and provide screening for women, and a lot of how we make that work is that we have to find the community partners, right? So we have to have community partnerships where the women are informed of the mammography, they're aware of what it means, they're aware of the benefits, and through these community partners, we can organize times for pickups, times for women to come and get screened. Then, of course, based on those findings, we have our navigators who can help. If they have a detected abnormality, we have to help the patients get diagnostic resolution.
Right, the follow-up is
exactly,
key.
And that's really the key, because you don't want to just screen and you're gone and say, thank you, here's what we found. That's only the beginning, right? You need to be able to provide the diagnostic resolution, and we have all of that covered. We really have a robust team of navigators who can take the patients through the whole thing. And unfortunately, if there's a cancer detected, those same navigators can help the patients get insurance, for example. If they need diagnostic workup, they can help them through the breast and cervical cancer program, BCCP. They can help them just get those services, and then if treatment is needed, they can help them facilitate that as well.
But for people and women who don't have health care coverage, you also have options.
Absolutely.
Yeah.
We have options, and we have to, because we have,
Yeah.
certain patients unfortunately are undocumented, so that's a population that's in need. We have a migrant population that's been in the news, and I think a lot of people don't think of Ohio. I certainly didn't know, right? I didn't, with the current media sort of focus on migrants, I didn't know there was a Haitian population. It was a Springfield. I had no idea. But there's so many different groups of people that are coming to our local areas, and those are groups that we need to reach. So part of what CCHE has to do is constantly we have to do evaluations of the community, because our area is so dynamic. It's very dynamic, and we have so many different groups, so many different languages. So the task that we have, sometimes it's a heavy lift, right? Because we need to have, if we're focusing on a Spanish-speaking population, we need to have navigators who are Spanish. We need to have literature that's in Spanish, right? We need to have follow-up and translation services. We also have a lot of African groups. We have Somali. We have, my family's from West Africa, so we have a decent-sized Ghanaian population. We work with them. So those all will require sort of a tailored approach to that outreach.
Yeah,
So
Columbus is much more diverse
it
than
really
I think
is.
people
Don't realize.
Yeah.
It really is. Ohio is, it's a whole. And definitely Franklin County. I think I've seen a statistic that 40% are foreign-born.
Of Franklin County.
Of Franklin County, yeah.
So
There's a robust amount of diversity here. So it's very exciting. But again, that brings us challenges when we're trying to, do our outreach and engagement with these groups.
It all comes down to the philosophy and the devotion that every human being deserves the best possible health care.
Absolutely. Absolutely. And we want them all to come here, right? Because as we said...
a comprehensive cancer center is the best place.
Yes, and we have data.
Better outcomes.
100%. We have data that shows that. And, and it's not to take anything away from our colleagues out in these communities, whether it's a non-metro or it's the inner city. We have colleagues there that work very hard to serve, these different populations. But we know we have certain... options here. We have clinical trials, for example, that they typically do not have, and that it's really is a benefit to get these populations to partake, to have access to some of these advancements.
Wow, so it's obvious your passion to reach out to everybody.
I want everybody to come.
But where does that come from? What motivates you to want to do more to help more people?
Well, I think growing up the way I grew up, I grew up in New York City, in the inner city, and it's just two worlds. But I also went to school in Brooklyn. So, I was really exposed to the haves and the have-nots. And my family was, working class, somewhere in the middle. We had healthcare, we had insurance and all of that, but definitely being exposed to people who didn't have that. And not only did they not have access, they also didn't have the knowledge. They didn't even know.
Yeah, to get screenings.
Yeah, they didn't know that you had to get screening. And they didn't know that, hey, if I go to the local hospital and they don't have something, or I'm not getting better from whatever condition, go downtown. That was a big divide. A lot of people that I grew up with in the Bronx never left the Bronx. Right. So my family, we would, if we needed to, we would go to Columbia, for example, or where I trained at MSK.
Not the country, the university.
No, the university. You go to Columbia University, which is downtown. But sometimes, certain populations is just, you just have that disconnect of knowing that you can even venture into a world outside of the community. Because let's be real, the facilities you may have in these vulnerable communities oftentimes are lacking in certain resources, right? So the expanse of what they can offer will be limited. And it takes that knowledge for that individual to know that, okay, I need to maybe go elsewhere, or I need to get a second opinion, or I need to question my provider. And again, those are all, that does not bother me. I actually love it. If you tell me you're getting a second opinion, please go. And if you find out something that I don't know, please come back and let me, and update me, because that's how it has to be. You want that person to be empowered and to advocate for themselves. I want to be your advocate, and I will do it if I can help you get transportation, if I can help you get additional insurance, if I can help you get financial support. But I also want you to advocate for yourself, because that's how it's sustainable, right? Because I may not always be around. Your navigator may not always be around. But if I can sort of instill in you the tools for you to learn to navigate the healthcare system, then you can take care of yourself. So that's really what I hope to be able to do for people.
Okay. Well, this was a great overview, and you're still a great teacher. Okay. So thank you.
Thank you.
I think women and men who listen to this will have a very good understanding of what they should do and the resources available to them here at the James and the Spielman.
Absolutely. And you just the last word on the men. We talked about a little bit in the beginning that men also have breasts. And I know some of them are like, well, no, I don't. Yeah, you do. You have some breast tissue, and about 1% of our cases will be in men. So again, men are not recommended to have routine screening. So it's really important for self-exam. So again, always, be vigilant, do that visual inspection, look in the mirror. It's simple. Look in the mirror and make sure nothing is changing. And if there's anything that's detected, please get medical attention.
Quickly.
Very quickly.
Yeah.
ASAP.
Okay. Thank you.
Thank you.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.